Let's get right into it. When you're evaluating a critically unstable trauma patient, you need a strictly protocolized approach. Literally, every second counts here. The sequence of your evaluation is exactly what dictates your clinical decision-making and ultimately whether the patient survives. Let's break down that next best step logic. Here's our game plan for today. We're running through the ATLS primary survey, airway and C-spine management, breathing emergencies, circulation and shock, and finally, inhalation injuries.
Starting off with Section 1, the ATLS Primary Survey.
The primary survey dictates your entire trauma management flow. We're talking airway with cervical spine protection, breathing, circulation, disability, and exposure. The classic ABCDs. Now, here is a massive exam trap. Do not, under any circumstances, jump to a CT scan before you've sequentially stabilized the airway, breathing, and circulation. Seriously, rolling a hemodynamically unstable patient into the CT scanner is a critical error. You've got to stabilize first.
Moving on to Section 2, airway and C-spine.
When you're dealing with high-energy mechanisms of injury, you want to apply the Nexus criteria. Basically, you absolutely need cervical spine imaging if you find a neurologic deficit, spinal tenderness, altered mental status, intoxication, or any distracting injury. But think about the next best step logic here. If literally none of those are present, a totally normal neurologic exam is completely sufficient to clear the C-spine clinically. You can safely skip the imaging.
That brings us to Section 3, breathing emergencies.
Take a look at this. In blunt chest trauma, your clinical logic branches entirely based on stability. If your patient is unstable, you proceed immediately to a bedside EFAST exam, a chest X-ray, and an ECG. CT scans shouldn't even cross your mind right now. That EFAST is going to quickly identify fluid, which lets you jump straight into stabilizing interventions, like throwing in a chest tube. And if you still can't achieve hemodynamic stability, that patient needs an OR thoracotomy right away. Now, if you see a patient with hemodynamic instability and their trachea is deviating away from the affected side, plus you're hearing ipsilateral hyperresonance and decreased breath sounds, that is a tension pneumothorax. This is a clinical diagnosis. It demands immediate needle decompression or chest tube placement. Do not wait around for an X-ray. You just don't have the time. You also really need to be able to differentiate a tension pneumothorax from a tracheobronchial injury. A tension pneumothorax gives you that classic midline shift and distended neck veins. But let's say you placed a chest tube for a pneumothorax, and it just persists with a really significant air leak, and there's zero midline shift. You need to suspect a tracheobronchial rupture. Also, keep an eye out for Hammond sign, that crunching sound synchronized with the heartbeat. Your definitive next best step here is a bronchoscopy to diagnose it, followed by surgical repair. Let's look at Section 4, circulation and shock. Hemorrhagic shock is by far the most common type of shock you'll see in trauma. You have to actively hunt for blood loss. Remember the phrase, blood on the floor and 4 more. External bleeding and the abdomen can each hold an entire circulating blood volume. The chest, that can hold about 40% per hemithorax. And crucially, the retroperitoneum of the pelvis can hide an entire blood volume all by itself. If you've got an unstable patient and you suspect an open book pelvic fracture is tearing up those venous plexuses, you need to apply a pelvic binder immediately. That reduces the pelvic volume and essentially tamponades the bleeding. Here's another major exam trap. Wasting precious time attempting central lines when peripheral IVs fail in a hypotensive patient. Don't do it. The next best step is immediate intraosseous, or IO, access. You'll usually go for the proximal tibia. It is so much faster and way safer during active resuscitation than poking around trying to find a central vein. All right, when it comes to damage control resuscitation, your first move is to control bleeding from any compressible site immediately. You want to activate your massive transfusion protocols early, specifically for patients who have a systolic blood pressure under 90, a pulse over 120, a positive FAST exam, or a penetrating mechanism of injury. Let's talk fluids. You really need to limit large volume crystalloids in hypotensive trauma. Keep it under 1 liter. Why? Because pumping a patient full of saline just dilutes whatever clotting factors they have left and actually makes their coagulopathy worse. Instead, you resuscitate with a massive transfusion protocol, a 1-to-1-to-1 ratio of fresh frozen plasma, packed red blood cells, and platelets. And if you don't have type-specific blood available, you give group O blood. Remember to specifically use O negative for women of childbearing potential and young girls, just to prevent alloimmunization. Finally, Section 5,
Inhalation injuries.
When you're dealing with enclosed space fires, thermal and chemical airway injuries are absolute killers. You need to look for strong indicators that require early intubation. We're talking oropharyngeal blistering, hoarseness, stridor, or carbonaceous sputum. If you see those, endotracheal intubation is your definitive next step. You have to secure that airway before worsening edema completely obstructs it. Now, if the patient is stable but you're concerned based on the history, doing a bedside fiber optic laryngoscopy is perfectly appropriate to check things out. Wrapping up, alongside damage control resuscitation, you have to remember this highly testable, time-sensitive intervention. For acute, life-threatening hemorrhage, you need to administer the antifibrinolytic agent tranexamic acid, or TXA. But here's the catch. It must be given within a strict 3-hour window from the time of injury to actually improve survival. Keep that timeline locked in.